Okie doke. This is the last session in our 4-part training. In this session, we will review the 3 studies with deadlines commissioned by the legislature in 2023. We'll focus on 2 issues the first of these studies must address: administrative costs and so-called low-value services. In the course of discussing administrative costs, I'll review how single-payer systems cut costs. The 2023 legislature commissioned numerous reports. 3 of them have deadlines. The first of the reports with the deadline is March 31, 2025. That report must recommend strategies to reduce administrative spending and low-value care. The Department of Health has informed us they will not be able to meet this deadline, but they are working on the study and they'll at least make a report on their progress before March 31. Stefan Gildemeister told us at our meeting in December, he thinks they'll have the whole report out by midsummer. The other 2 reports with deadlines have the same deadline, January 15, 2026. One is a report due from DHS on how much money Minnesota could save by removing the HMOs from our Medicaid program and Minnesota Care programs. And the other is due from the Department of Health on how much universal health insurance under the Minnesota Health Plan, our single payer bill, would cost compared to the current system. The 2023 legislature also set up something called the Center for Healthcare Affordability within the Department of Health. I don't know why a separate office had to be created, but in any event, they did that and authorized this office to comment about anything under the sun related to healthcare costs, including, now screw on your thinking cap, a plan to assess readiness of rural communities and rural healthcare providers to adopt value-based global budgeting or alternative payment systems. And you won't be surprised to know nowhere in the bill did they explain these nice, trendy, manipulative terms. We interpret these blue line words to mean the Center for Healthcare Affordability is supposed to dream up a plan to impose ACOs on rural hospitals and clinics. We'd love to test that in a conversation with the Department of Health. We so far haven't had a chance to get to it. All right, so now I turn to the first big topic that the Department of Health has to comment on in its March report, and will have to comment on in its report on the Minnesota Health Plan: administrative costs. And I begin with a discussion of single payer because if we could wave a wand, we'd make the Department of Health recommend a single payer system as the single best way to reduce administrative costs. Here's the definition of single payer. One payer replaces 1,000 or so insurance companies at the national level, and at the state level, several hundred insurance companies. Second, the one payer negotiates budgets with institutional providers. Third, the one payer negotiates uniform fee schedules with individual providers. And fourth, the one payer negotiates limits on drug prices with drug companies. Now, this is a quick overview of how a national single payer would save money, easily up to 20%, possibly more as the years go by. You see that the bulk of the savings comes from reduced administrative costs, 15%. And roughly speaking, half of that savings comes from the insurance sector, insurance companies, self-insured employers, public programs, and the other half comes from hospitals and doctors, the so-called provider sector. You see there's another 4% in savings from reduced drug prices and 1% in the form of reduced fraud. It's just easier to detect fraud when you've got one computer accepting all claims. Now let's look first at the top level, at the highest level. Research indicates that of the nearly $5 trillion that the US spends every year on healthcare, 34% is spent on administration. Now, obviously, you can't say all of that is wasted, but you realize that the comparable number is 17% in Canada. You can say, yeah, half of what we spend on administration in this country is wasted. If you subtract 17 from 34 and round down, you get this 15% figure I showed you in the last slide. Now I come back to our blue-green mountain slide. The U.S. did not always spend 34% of total spending on administrative costs. Here, back in the days of yore, we were spending a lot less on administration. This graph shows that administrative costs since 1970, the year our friend Paul Elwood invented the HMO concept, have soared. You can see our administrative costs rose rapidly in the late 80s and early 90s as managed care tactics spread. You see the rate of growth slowed somewhat in the late 90s, but spending on administration has continued to climb rapidly, due in part to the privatization of Medicare and Medicaid, and in part to the layering of value-based payment schemes, mainly ACOs, on top of an already complex multiple payer managed care system. Now, for the next several slides, I want to introduce you to the measurement of administrative costs at various levels, because that's what the department has to do if they're going to do their job well. That's what DHS has to do if they're going to do their job well on our deprivatization study. We've already seen 34% administrative spending at the system level. Now we're going to look at the insurer and provider level. The traditional Medicare program only spends 1 to 2 cents of every tax dollar it takes in on running its shop, on administration. They pay out 98 to 99 cents of every dollar they get to doctors and hospitals. Canada has a similar ratio. They have a single payer system. State Medicaid programs before privatization, the agencies, now I'm not talking about the insurance companies, the agencies spend 4 to 5% of their expenditures on running the Medicaid office. Why would the Medicaid's overhead be this high and Medicare's is this high? Answer, because unlike Medicare, Medicaid is means tested. Applicants have to tell us what their income is, what their assets are, and we have to hire people at DHS to look over their applications and decide whether they qualify. Economies of scale probably plays a role here, but I think the means testing of Medicaid explains this difference. Insurance companies are by far the least efficient way to insure people. Their overhead is 20%. You give them $1 worth of premiums, they keep 20 cents to tell doctors how to practice medicine, market, overpay their executives, lobby, construct narrow networks. When insurance companies are inserted into Medicaid and Medicare, their overhead costs drop to 15%. I've never seen a good study on this, but I'm fairly confident that the reason you see this difference, 20% versus 15, is that once insurance companies are inside a public program, they no longer are responsible for collecting premiums. The government is doing that for them, and that reduces their administrative costs. You see, for most providers, they're spending about 25% of their expenditures administering the system. And a lot of this is spent just coping with the American insurance companies. I want to document what I just said about insurance company overhead being 20%. Here we have a graph prepared by AHIP, America's Health Insurance Plans. This is from the horse's mouth. They're saying their overhead is 21%. You see the little graph they made. They say we spend 80% on medical expenses. Looks more like 79%. And they're saying our overhead, operating costs, and our profit take up 21%. Now I want to come back to this statement I made about Medicaid before privatization, 4 to 5%. This is the documentation. There are several documents we could refer to. This is from the final report to the legislature, the first commission that was recommending HMOs and PPOs, 1991. It said the commission found a wide variation in administrative costs from a low of 4 to 5% for Minnesota's Medicaid medical assistance program to highs of over 20% in some private insurance plans. This, I just show you quickly, there were some experts who said that when states privatize their Medicaid program, they're going to drive up the administrative costs of the Medicaid agency. It's bad enough that you're inserting HMO overhead costs into the program, but you might also increase the agency's overhead. Don't have good research on that. Can't go out and say DHS's overhead doubled after the legislature privatized Medicaid. But you can see here, Michael Sparrow, national expert on Medicaid, speculated Medicaid and managed care actually increases the state's regulatory role. We have asked DHS, what is your overhead now? Because that would tell us if their overhead has gone up since Medicaid was privatized, and we know it's 4 to 5% in the early 90s, we could get an answer to the question. No answer yet. I just discovered this study about a week ago, and so I just couldn't resist preparing a slide for it. As I think many of you know, Connecticut went along with the herd and privatized their Medicaid program, I think in the late 90s. In 2010, they said, shoot, this isn't working. And they deprivatized. They kicked the HMOs out of their Medicaid program. I think they call it the Husky program. But the governor said, oh, you know, it's about time to stick the HMOs back into our Medicaid program. And he got holy hell for suggesting it. And the solution was to hire some consultants to report on that idea. And they came back and said, they find that Connecticut's program stands out as a model of cost efficiency. Per capita spending 14% lower, average of most Northeastern states, and administrative costs significantly lower than managed care states. So you take that statement and some other research, there's some other consultants that have said, if you privatize your Medicaid program, your costs are going to go up 10 to 15%. Well, on the basis of that Connecticut report and some other research, we don't have a lot, I think it's safe to say that deprivatizing medical assistance in Minnesota care would cut total spending by 10 to 15%, because we're no longer paying for HMO overhead costs. And the reason why I have to do a range here is because the HMOs are a black box, we don't really have a good understanding of what they do to utilization. We know they irritate a lot of patients by denying necessary services, but we've got some research that says overall they don't change utilization, and some saying they reduce utilization by 5%. If that's the case, if they do reduce utilization by 5%, kicking them out means that total spending will rise by about 5% as utilization rises, and the net savings will be 10%. But if they really don't influence utilization, then the net savings will be 15%. And notice that this little calculation does not take into account reduced administrative prices for clinics and hospitals that will occur with deprivatization. Now I returned to finish off our investigation, our survey of administrative costs at various levels of the system. I'll look briefly at hospitals. This is from a paper published in 2014. Reported that the average US hospital spends 25% of its expenditures on administration. The comparable number in countries with single payer systems is 12 to 13%. So this is just one of the places where we will see reduced administrative costs if we could get to a national single payer. Maybe ideally, we'd even see a slight reduction in Minnesota just from deprivatizing medical assistance in Minnesota care. This is the most irritating slide you will see in the entire session. The authors asked an interesting question. What happened to hospital overhead during the period 81 to 1993 when managed care cost control tactics were spreading like wildfire through the system? And they found that over that time, total hospital employment rose by 11%. But look what happened to administration. That class of employee rose by 46.5%. Well, not to worry about, oh, wait, to make room for all these paper shufflers, we're going to cut nursing. Crazy system. Last comment on administrative costs. This is data for 2006 about how much it costs a doctor in Canada versus the US to get paid. You see the average American doctor had to pay $83,000 dealing with insurance companies to get paid. Comparable number for the Canadian docs was $21,000. Here's a more updated article, 2018. The new price tag is $99,000 annually to get paid. Now I come back to the article that you saw earlier on Korenstein et al., because now I want to finish up by discussing the second big topic that the Department of Health has to report on in March, and that's the alleged low-value care or overuse. You recall that Deborah Korenstein and her colleagues looked at 115,000 articles looking for overuse. They found only 172. And they said those articles really focused on just 4 services: antibiotics for upper respiratory infections and 3 cardiovascular procedures. The question is that I want to take up with you is, why did Korenstein and her colleagues find so little research documenting overuse? This is a very important question, because as you work with legislators, you'll probably encounter some who are totally sold on the claim that we need insurance companies to crack down on overuse. A complete answer to that question takes more time to present than I have in this video, so we're going to produce a separate 10-minute video just on that question. I'll give you a brief answer in the remainder of this session. The short answer is that Korenstein and her colleagues found very little research documenting overuse because they insisted on reviewing only rigorous research, and very little research on overuse is rigorous. The next question that will occur to most people is, if rigorous research is sparse, why do so many legislators and experts believe the overuse excuse for managed care? There are 2 answers. One, because many studies that claim to find overuse used grossly inaccurate measurements, but editors of prestigious journals published it anyway. And 2, because in the late 1980s, the insurance industry began pouring a lot of money into promoting the overuse excuse for their behavior. Limiting patient choice, exposing doctors to financial incentives, telling doctors what services they could order. Korenstein and her colleagues included in their review only studies that use what is called the appropriateness method. It was developed by the Rand Corporation in the 1980s. Korenstein et al. Did not include studies from the 2 other types of overuse research: regional variation studies, mainly based out of the so-called Dartmouth Atlas, and low-value care services, which began to spring up around 2012. Why? Because that research is simply not rigorous, to put it politely. In the separate video I mentioned we are developing, we'll show you why the regional variation and low-value services research is so inaccurate that we cannot trust it to tell us how much overuse exists. I'm going to focus in the last few minutes here on appropriateness research. The appropriateness method is not rocket science. It's the method you or I would invent if we were asked to measure overuse of a medical service. It requires the existence of a well-researched guideline for when a service should be provided, and there are guidelines missing for lots of medical services, so you got to start with a good guideline. It requires pulling actual medical records of patients who received the service, and it requires that physicians with expertise in providing the service in question review the patient records and determine what % of the patients received the service in accordance with the guidelines. So I hope you're already getting a picture of how expensive this appropriateness style research is. Let's take a look at imaging for back pain to illustrate the appropriateness method. Good research has developed guidelines for when it's appropriate to subject patients diagnosed with low back pain to x-rays, CAT scans, or MRIs. You see a guideline in this slide developed by the American College of Radiology. And the guideline reads, imaging is considered in those patients who have had up to 6 weeks of medical management and physical therapy that resulted in little or no improvement. It is also considered for those patients presenting with red flags, raising suspicions for a serious underlying condition, such as, I think I'm saying it correctly, Cauda equina syndrome. I think that's what Luigi Mangione suffers from, cancer, fracture, or infection. Investigators using the appropriateness method would pick a guideline like this, pull records off several hundred patients who received imaging for low back pain, and they'd send the guideline to a dozen experts and ask them to rate the treatment given to the patients as appropriate or inappropriate. A recent review of imaging for low back pain excluded studies that didn't use the appropriateness method, found 9% of the images were inappropriate because they were done within 4 to 6 weeks after the diagnosis of low back pain without evidence of one of those red flag conditions in the medical record. Interestingly, that same study also found underuse rates of 61 to 66%. I just told you that they found an overuse rate of 9%, but an underuse rate of 61 to 66%. Need to educate the agencies, legislators on the very high rate of underuse for many medical services. Note that we're not claiming that overuse does not exist. We're saying documented overuse is relatively rare, and it's not the problem Minnesota should have focused on the last 50 years. The only acceptable solution to overuse is more research on what medical services work, for which patients, and more education of doctors and patients about that research. If we're not successful in conveying that message to the agencies and the legislature might endorse even harsher managed care tactics, including even more prior authorization than we're dealing with now. So that's my presentation. Summary of this session: the reports commissioned by the 2023 legislature give us an opportunity to educate the legislature, agencies, and the public about why nothing to cut costs has worked. First of these studies is due in March. Must recommend strategies for reducing administrative costs and related services. Now, this is critical. If DHS measures administrative costs and overuse accurately, their report on deprivatization will conclude deprivatization will cut spending by at least 10%. If MDH measures administrative costs and overuse accurately, it will report that the Minnesota Health Plan will achieve substantial savings. Very little research documenting overuse.
This concludes the 4-part training series, Why Have Minnesota's Healthcare Cost Containment Policies Failed? Thank you for watching this video. See the description below for links to the primary sources used during this training. Healthcare for All Minnesota has more videos and looks forward to you joining our efforts.